Hi friends, and welcome back to my channel. If you are new around here, my name is Julia and I am a graduating 4th year medical student. So you are catching us at the second part of my emergency medicine rotation. So in the first video, I introduced you guys to the field of emergency medicine, which is basically the assessment, diagnosis, and treatment of acute illnesses and injuries in the emergency department. I truly believe that emergency medicine docs are the jack of all trades, and they are experts when it comes to quickly assessing and diagnosing patients and assorting them to the proper part of the hospital so that they can get the further care that they need. If you guys did not check out that first part of the emergency medicine rotation, be sure to do that, as there is a lot of great information in there. So in this vlog, I'm going to take you guys along with me through my last few emergency medicine shifts, as well as break down a few of the clinical cases that I got to see in the emergency room. It's the first time I'm going to do something at this level like this, so I hope you guys like it. Alright guys, so here is a room separate from the main ED that is used for gynecological exams. So pelvic exams, you can see the stirrups up there. So I'm getting ready to bring in one of my patients that we need to do a pelvic exam on. Alright friends, so here you see me setting up the examination room by putting a sheet on the bed so the patient is comfortable. I'm also setting up my examination table with all of the materials I will need for the exam. I'm doing this myself because the nurses are often overwhelmed and hey, work's gotta get done. So to review the materials I use, I'm going to use a plastic speculum, which I will coat with lubrication so the woman's comfortable. I also have a variety of swabs and cultures to run further tests. And we're set. Woo! Today was a wild day, you guys. So I'm just getting out. It's a little after 3. I worked the morning shift today and I messed up. So when I made my emergency medicine rotation schedule at the beginning of this whole 4-week experience, they told us that residents have didactics, or they're learning on Wednesdays. So if you're going to take a Wednesday shift, like be aware that you're going to be working like a resident, because the supervisor doctors are by themselves. They don't have residents on Wednesdays. I don't know how I messed up and took a Wednesday shift, but here I am. So I was working, y'all. Like, I was working like a resident. So I was really seeing patient after patient after patient, because to be frank, like, sometimes the supervising doctors, when they have residents to do these things for them, they literally just have to supervise, right? So take out the workforce, and that really kind of is like a lot on their shoulders. So me as a medical student got a lot more responsibility today. So I was seeing patients, I was literally like discussing what I think, putting in orders, helping the nurses do IVs, doing exams, so it was just a wild day. It was a great experience. I feel like I truly felt like how I'm gonna feel as an intern, but I was just like, damn, like, I thought this was gonna be chill. I'm a 4th year, this is the time to relax. But it was really cool. I saw some really crazy cases, you guys. I had a woman who had chest pain, but she had done cocaine last night. So everybody was kind of chalking it up to, oh, it's just cocaine-induced vasospasm, right? Textbook, this is what we learn about. Until the doctor was like, I don't know, the type of pain she's in is like a little much. So we got a CT of the chest with contrast, like an angio. And it showed that she had an aortic dissection, you guys. Like, this is like classic textbook stuff. Somebody with hypertension that does cocaine, comes in with super high blood pressures and has an aortic dissection. And then, it's like, okay, it goes from, oh, this is just gonna wear off and it's just a vasospasm, to holy crap, we got to get this girl to the OR because she might die. This is severe. So they rushed her to the OR, you guys. Like, it was crazy. Then I got a patient who has kind of like involuntary writhing movements, looked kind of like a Huntington's type of picture. If you guys haven't seen that in person or in the clinical setting, definitely go Google that. But then she also has a significant psych history. So we're like, is this psychogenic, like involuntary movements because of her mental health, so very, very interesting stuff today, in addition to a few other cases. So it was a great day. All right, guys, so it is time for our clinical case. So This is the first time I'm doing something like this in the vlog, but I thought it was really, really interesting. This case that I came across with the aortic dissection, the woman that did cocaine. And I thought that this would be a great teaching point because this is something that you will see a lot in the textbook in medical school or in your practice questions and whatnot, but that you don't often see in clinical practice. It was my first time seeing it as a medical student on any of my rotations, so it was awesome. Nonetheless, it was very scary for the patient. So I want to go through the case with you guys, explain kind of the history and how she presented to the ED, as well as go through the imaging that we got and show you how we got to the conclusion that the woman was having this severe aortic dissection. All right, so here we are, a Wednesday morning. I'm told to go see the patient in room 8 and then come present the case to the attending. There were no residents this day, so it was simply just me and the attending physician working together. So I go see the patient in room 8. She is a 49-year-old woman with a history of uncontrolled hypertension or high blood pressure. She states that she doesn't really take her meds. She hasn't seen her doctor in over a year because it's been hard to get an appointment because of the pandemic. She's not taking any of the prescribed medications for well over a year, and she doesn't check her blood pressure at home. She states that she did cocaine at about 9 p.m. last night. She woke up this morning for work and she had all of a sudden excruciating chest pain, 10 out of 10, located right here. And she's never experienced anything like this before. You guys, when she comes to the emergency room, her blood pressure is like 220 over 130 or something like that. She's writhing in pain on the bed, trying to get comfortable, doing everything she can, you know. She's screaming that she's never experienced pain like this. So in the ED, time is money, right? So you only have so much time to get a history and do a physical before there's more patients coming in and coming out, right? As medical students, we have a little more privilege to spend more time with the patients because we don't have all of the responsibilities that residents and attendings do. However, the way that this woman was in pain and there were no real physical exam findings for the patient, you know, her heart and lungs sounded good. She looked well with the exception of the pain that she was in. So I quickly go find the attending, I present the case to him, and you know, we're talking through the assessment of this patient, what we think's going on. Is this just a hypertensive crisis, right? Is her blood pressure just extremely high and maybe she's having, you know, some vasospasm? Her heart is pumping too hard, right? It's overwhelmed because of her blood pressure and the cocaine that she did, often called a cocaine-induced vasospasm, right? Her heart is just freaking out essentially, right? Because it's in overdrive because of the stimulants that she did last night. However, when you're in the emergency department setting, you are always concerned with not missing fatal diagnoses, right? And that's a major problem that results in over-testing and things like that that we see in the emergency room because simply doctors will not take the risk of missing something, right? Something that could potentially be extremely dangerous and fatal for the patient. So me and the attending are talking through it and we're just like, you know, it could just be blood pressure, cocaine-induced vasospasm related. Maybe we can do some further imaging just to make sure she doesn't have a stroke or have a heart attack or something like that. But it'll probably just go away, right? In my mind, I'm just like, you know, we read about this. It might just go away. She might just need to, you know, let the stimulant work out of her system and then her heart will slow down and she'll go back to normal. However, this is why attending physicians have the experience and they are in the position they are in because they have the experience behind them to know what to look for. So he said, Julia, do you think she's in a lot of pain right now? And I was like, absolutely. And he was like, her pain is disproportional, right? To what you're finding on her physical exam. You're not really finding anything, but she's in this excruciating pain, more so than maybe a vasospasm would cause. So he's like, I think I'm gonna do some imaging of her chest to make sure that her aorta is intact, right? The vessel that distributes blood from your heart to the rest of your body. So we give her some pain medication so that she's comfortable. We send her off to the CT scanner to do this imaging of her chest. She comes back to the emergency room and immediately thereafter the images were already read by the radiologist because it was an emergency, and she is diagnosed with an aortic dissection, which could be a very dangerous, fatal diagnosis. So what I want to do right now is briefly go over the anatomy of the heart and go through what exactly an aortic dissection is and why this matters in the clinical context of the emergency room. So just to review, the heart is the main pump for the body, and it is responsible for distributing blood to all of the organs that in your body that need it. It distributes this blood by vessels called arteries, right? So the aorta is the largest vessel in the body. It comes off of the heart through the chamber, one of the chambers called the left ventricle. There are 4 chambers in the heart, and it comes off of the heart through the left ventricle through the aortic root, and it kind of does this curved ascending part of the vessel, and then it comes around and descends through the rest of the body, down through the trunk, and then it starts to kind of diverge into smaller arteries. So when we are talking about aortic dissection, we are talking about the aortic root as well as the ascending and descending aorta. So what exactly is an aortic dissection, right? Well, the aorta is a vessel, and it has many layers that line it. And those layers are the inner layer, the intima, the middle layer or the media, and the outer layer called the adventitia. And basically what happens is that in that innermost thin layer, there's a rip in it. And this is caused by many different things, including high blood pressure, plaques caused by high cholesterol and fats. And this rip or hole in the pipe creates an escape for blood to flow through in an area that it's not supposed to be, right? So we call this a lumen or a false lumen because it's not truly where the blood is supposed to be, and it pools there and just is not supposed to be there. And sometimes that blood in that lumen can stay pretty stable, right? Or the hole is very small and only a little bit of blood leaks out, and we can just watch it and manage it to make sure that it doesn't cause any problems. However, other times that hole and that blood pooling in that false lumen can become very problematic and can grow, can cause blood loss because that's all blood that isn't able to be distributed to the body. It can spread and stretch down more of the aorta, and ultimately it can also rupture. So when we're talking about the aorta, the largest vessel of the body, and it carrying all of this blood, right? A rupture, even it pooling a lot of the blood supply can be very destructive to the body, right? Because that is all blood that is not in the circulation, that is not going to your brain or your stomach or your kidneys. So this is a very serious problem. And lastly, there are different types of aortic dissections. There are some that include the aortic root that comes off of the left ventricle. There's some that include the ascending aorta, the descending aorta, or a mixture of all of those. The reason why classifying which type of aortic dissection the patient has is important is because the management and treatment for the different kinds of dissection varies. So there are some that require surgical intervention because it can be fatal, and there are others that can be managed by just medicine or maintaining your blood pressure and heart rate because they are generally stable. So now we're going to look at the imaging that we got for this patient. So this is the CT angio of the chest. So this basically means that we injected contrast into the patient and we looked at the arteries and the blood flow throughout the patient's chest. So I'm going to scroll up through the image. So this is starting basically from the bottom up. So we are going to come up through the abdomen. You will start to see some kidneys, the liver, the bowel. Then we see the heart. And let me know if you guys can see the dissection. I'm going to take it back a little bit. And there we have on the left the ascending aorta with the dissection clearly across it. So as you guys can see, there is a clear flap in the patient's aorta, right? So this is that false lumen that is created because the intima, that inner layer, got ripped and there is blood pooling in a false lumen. This is aortic dissection. So once the patient was determined to have an aortic dissection, it had to be classified by which type. And it was determined that she did indeed have an ascending aortic dissection, which included that aortic root. Why that's important, you guys, is because basically what can happen is that if that root is affected, that can cause blood to either pull back into the heart or blood to not really pump out of the heart correctly. So it just can be very, very fatal. Whereas the descending aortic dissections, the ones that are more down on your trunk, that aren't really centrally located at the heart, or at least the pumping of the heart, can more so just be medically managed, right? So you can just control the patient's heart rate or blood pressure and make sure it doesn't grow or become more problematic. But sometimes it doesn't require surgery at all. But this patient was determined to have a very serious, fatal aortic dissection, and she was immediately rushed to the operating room and it was repaired. So I just wanted to go through this case with you guys because not only is it super cool to see, but also it's textbook, right? All of the stuff that you're taught to learn over medical school that you question why because you don't really see it often clinically, but these are the reasons why, because although it may not happen often or is frequent where you may be or where you're training, it happens, and you have to know what to do, what the proper tests are, what the proper imaging is, what is the treatment, who do you need to call so that the patient can be treated and that it doesn't necessarily have to result in mortality. This patient had her surgery and she's doing well, she's discharged, she's home, you know, and I'm sure she's having very close monitor and follow up with cardiologists and things like that to make sure she stays compliant with her medications. But this could have gone a whole nother direction, right? If even it was a little bit more time, or if my attending physician was just like, I'm gonna chalk it up to cocaine-induced vasospasm or just hypertensive emergency or something, you know? So thought it was a really cool case to go through and show you guys kind of the importance of the textbook learning, but also how that informs your clinical diagnosis and treatment. So I hope you guys enjoyed. All right, guys, so the next quick case that I want to go through is of a young woman who was in the shower and she slipped while she was cleaning and she fell on her outstretched hands and basically fractured her wrist. So what happened is that she went to one hospital and they basically just splinted it up and told her to schedule an appointment outpatient with an orthopedic doctor, right? But because of COVID and everything, she couldn't get an appointment until June. She went home and she was in excruciating pain for days, you guys, until she presented to our emergency room, just not being able to bear it any longer. At that time, we did new x-rays and I'll show you guys what it looked like. So we took x-rays of the patient's wrist, it was her left wrist, and as you can see in this x-ray, the patient's radius, or the larger bone, the skinnier, smaller bone is called the ulna, has a large fracture at the head. So you can see the jagged areas along that top of the head, the top of the bone. And you can especially see the extent of the fracture here in the lateral view, where you can see that the bones are just completely in opposite ways. This totally explained why the patient was in so much pain. Her fracture was not at all in the location or fixed in the place that it was supposed to be in order to heal appropriately. So what I did was I jumped on the phone and consulted orthopedics in the hospital. So I called them and gave them a quick description and history of what happened with the patient, and they came down and saw the patient. So the orthopedic surgeons came and evaluated the patient in the emergency room, and they did their own x-rays and determined that the patient's fracture was just not appropriately reduced and fixed in a way in which it could heal appropriately. So we had to do a reduction and fixation in the emergency room. So I got to assist the orthopedic surgeons with that, and it's a whole ordeal, very painful for the patient. But we essentially sling the arm and pull it. We pull it and fix it so that those bones are aligned so that they can heal. And then they re-splint it so that it's fixed, so that the bones are aligned in the right way so that they can heal, and that they are fixed in place so that they don't move or, you know, break apart again, essentially. During that whole process of reducing it and tugging on it and pulling on it, we were taking x-rays with this really cool bulky machine to basically see how we were doing with kind of reducing it and putting it back in place. It was really cool to be a part of. I was so fortunate that the orthopedic surgeon allowed me to be there with him and help him and just assist, because I'm not gonna do that ever probably again in my life, you know? So it was really cool to have that experience. So although the whole ordeal was extremely painful for the patient, we did give her some pain medications. We got it reduced and fixed, and she is now following with our orthopedics department to ensure that it continues to heal appropriately. Woo, you guys, it is Friday night. 11:17. I just got out of my 3 to 11 shift. I was in the peds emergency room, and it was a wild, eventful Friday night, you guys. Like, hold on, we just got to recap all of this. Today did it, you guys. Today is when I realized I've had my fill of emergency medicine. I have 2 shifts left, 1 tomorrow and then 1 like next weekend overnight or something. But I am running out of this hospital tomorrow after my shift, getting on a plane and going to Puerto Rico. Thank heavens, because I'm tapped out. It's too much for me. It's too much, you know? Today, the day started off fine. You know, I was on the 3 to 11 shift. I came in, I immediately saw a patient, very just kind of straightforward, has kind of just like an upper respiratory infection, essentially a common cold. So what do? You don't really need to come to the hospital for those things, but in pediatric emergency medicine, parents get very cautious, very concerned. You know, the threshold is very low for parents to bring their children to the emergency room. And I don't blame them, you know what I mean? Like, if it was my child, they're coming to the emergency room if they look the wrong way, you know, like, so I get it. But the common cold is common in kids, right? They're snotty-nosed kids, they're dirty, you know, they play with germs, they pick their boogers, they eat them, they touch everything, put everything in their mouth, so they're gonna get sick. But it was just a little kid, 3-year-old kid, had a common cold, was running around playing, looked totally in good health. So what do? Give him some Tylenol, send him home. So that was my first patient, very straightforward. I had a patient with kind of like some social issues at home, a little baby who had some injuries that alerted us to involve Child Protective Services. So that did not go over well with the family whatsoever. And you know, it caused a lot of commotion. It caused a very intense, heated, verbal interaction in the emergency room and in the hospital. And that took up a lot of my shift today, you guys. I was dealing with that for about 5 hours. I had seen the baby, like I was the first one to see and evaluate the baby and kind of talk with the parents and stuff. So I was the main one that kind of built that relationship and that rapport, which was a blessing and a curse, because like in the heat of everything that was going on, I was the only one that was able to kind of de-escalate and talk them down and like kind of get through to them. But then it was also like, I kind of had to be in the thick of it and be the liaison with CPS and everything. So it was just it was a lot that I've never had to deal with before. And it was like, okay, this is emotionally draining. And at some point I even had to step away and compose myself, because it was just like, I'm very sensitive in general, you guys. Like, I'm a very sensitive person. I wear my heart on my sleeve. I cry more than probably I do anything. But something about children and kids and them just being like innocent little beings that, you know, are products of their environment and don't have necessarily a say in their home life or their upbringing or, you know, who their family is and things like that. Something about kids in particular, just, I have a very low threshold with my emotional capacity when it comes to kids. Like, and this was just one of those situations that just sucked all around for everyone, for probably the baby, for the family, for the providers, for Child Protective Services. And it was just like one of those things that was like, I don't like this. Like, I don't like dealing with this. I don't like being in the mix of this. I don't like feeling like I can't really contribute or do much to help this whole situation. You know what I mean? And then providers, because we have a duty and obligation to kind of alert the services and the peoples and the powers that be when children are involved and that there's injuries like this and stuff, like, we're kind of looked at as the bad guys, like we're trying to tear families apart or whatnot. And it's like, like, that sucks even more, because you're just doing your job and you're just trying to make sure people are safe and that, you know, everything's okay. And it's like, it was just a shitty situation, I'm not gonna lie, you guys. And I was like, I don't want to go into pediatrics. Like, I do not want to deal with this, because I'm I'm damn near in tears over here. I had to step into the supply closet to cry it out because this just doesn't feel good, you know? So it was just not a good situation, and it was basically the entirety of my shift today, and I was like, save me. So no thank you. But luckily I only have 2 more shifts left, you guys. I have a week-long vacation coming up to Puerto Rico. I need it. And then match day is coming up 2 weeks from today, you guys, is match day. I'm gonna find out where I'm going to residency, what I'm doing post-graduation. Do I have a job or not? If I do have a job, where is that job? Where am I relocating? So I wanted to make sure that I was off and that I wasn't gonna have to be juggling emergency medicine shifts during that time. So that's why I front loaded a lot of my shifts. So I did a lot of them in the first 2 weeks, and that's why I only have 2 more shifts left. So hopefully we can continue seeing some good cases over the next 2 shifts as we finish out this last rotation of medical school and my last video, most likely in this Rotate With Me vlog series. So let's see, you guys, let's get to it. You guys, I just had a cardiac arrest, a code blue. You can see, oh my gosh. It is 2:30 in the morning. I came in at 11 and I've been working on this patient, literally doing compressions, trying to keep this guy alive. Like, okay, let me take a break and then we'll talk about it, okay? All right, guys, so what a night. I look a mess, but it's been a night thus far. So it is currently 3:30, you guys. I came in for the night shift, so I came in at 11. I'm in the main ED today, so I'm on the high side with the higher number beds, which includes traumas. So we get a call from EMS that they're bringing in an older gentleman that went down and is in cardiac arrest. So they let us know that they're on the way to the hospital so that like we could prepare, right? So that we can have all the staff that we need, all the resources that we need in order to tend to this patient that's literally like, you know, trying to be revived. So we're all kind of geared up, PPE, you know, you don't know a patient's COVID status. So we're all ready to go, gloved up, geared up. And we're standing around waiting. It felt like forever for this patient to get to the ED. But eventually the EMS pulls up. You know, they have this machine doing compressions. So much more efficient than manually doing compressions, like person. But still, it's like this artificial machine doing compressions, and they're rolling him into the room, and the EMS woman starts yelling out kind of the history of what happened, how he's an older gentleman, his past medical history, what happened, what he was doing, the information that they gathered from the family, how long he's been down, what they gave him in the field. They gave him epinephrine and bicarb, and you know how long they've been doing compressions, if he has any pulses, all of this stuff. So all of this information that EMS is giving us is super helpful, right, to kind of get a sense of how severe this is, or like kind of the measures that have been taken thus far and if they were successful or not. But once he gets to our ED, it's a clean slate, right? So we start the process all over again. So we get their machine off and then we start doing manual compressions. So I start doing the compressions. The residents like, Julia, you're on compressions as soon as that machine comes off, right? So I'm like, damn, I haven't done compressions since probably my internal medicine rotation in 3rd year, you know, when I showed you guys in my Rotate With Me medical vlog, my first code blue. So I was like, I'm a bit rusty. I didn't even remember how to hold my hands, like, you know. So I get on, I start doing compressions. It felt like I was on his body for like 5 minutes, you guys. And it's crazy because the first pump, the first compression, right? I'm here. I had to get a step stool because, you know, you need to have good kind of compression over the body. So I got on a step stool and I'm leaning over his bed. The first compression I did, you guys, I hear the crack of his ribs. And I'm like, am I strong or is this man weak? And he was a very fragile, kind of frail older gentleman. But I'm like, oh, like to literally like feel and hear his ribs crack under my fingers was like, oh my gosh, and this is the things that like the book doesn't teach you, right? And this is the stuff that's like the real deal, the medicine that you're going to experience once you are a doctor. So, I just compressed away and I went for the entire round. I don't know how many seconds it is. I think it's like a minute or a minute and a half or something like that. But when you're going full speed, you guys, like, it's a lot. It's a workout. And I was like, had to breathe, and I was breaking a sweat through like my mask and my gown and everything. So they're like, let us know when you get tired. And I was like, all right. So I went the entire round and then we stopped, checked for pulses, and he didn't have pulses. So back on again. So boom, I'm back on the body. And they're like, did you get a break yet? And I'm like, no. And they're like, all right, like when you're ready, swap out. Like, so I was like, all right. And the guy's lined up next to me and he's like, let me know when you're ready. So I counted him in. I was like, all right, 3, 2, 1, boom. And we swapped out. And eventually we actually got pulses back on the guy. So he's in the ER right now, not doing too well, but he is alive. And his family was able to come and sit at his bedside and they're with him right now. But they made the tough decision to make him DNR, DNI. So basically do not resuscitate or do not intubate. So basically no further measures if he were to code again. A lot of families make this decision because it's just, if what you're doing isn't contributing to kind of the betterment of the health of the person, and rather you're just prolonging life, but not really with a high quality of life, then a lot of families will just be like, they wouldn't want this, right? The patient wouldn't want this. So they made him DNR, DNI. So if he were to code again tonight, on our rotation or at any time in the future, we would not resuscitate him. We would not do CPR. We would let him go naturally. So his blood pressure and heart rate and everything are pretty unstable. So I have a strong feeling that he might not make it through this shift, unfortunately. But luckily he has his loved ones at his bedside that, can be with him if it were his time. But it was a crazy cardiac arrest, you guys. It was, oddly enough, like I was pretty composed during it, and like I was like, all right, what do we need? Like, let's go. The hype of being the first one wore off during my third year when I had that code blue. So now I was a little bit more familiar, but still, like, you never really get used to just seeing people literally on the cusp of life. And that's not something that's ever going to kind of, I don't think, sit right in my spirit. But as healthcare providers, we do what we can to, help individuals continue their life with their quality intact. So I was grateful to be a part of that experience and to not have to lose him. So that was my code blue, my cardiac arrest, you guys, for the night. We were literally working on him for over like 2 hours or something like that. And he's still an ongoing, patient that we're tending to around the clock. Like he's very unstable. So I'm constantly in and out, checking on him, checking his heart rate, his blood pressure, and all of that. So that was like my main case for tonight. I walked in and within an hour, it was like, that was the first patient I'm seeing, so that was that. I also have another patient who has a colostomy bag. So she's had part of her colon removed because of cervical cancer, and she needs like new colostomy bags. Like she's been having a hard time getting the supplies and having them changed out and stuff. So that's something I'm also going to do is kind of clean her area on her stomach and on her ostomy bag, and hook her up with some new ones to go home. So it's been a very eventful night so far. I have about, 3.5 hours left. I need a break. Luckily, you guys, when I get home in the morning, I am going to sleep for a bit and then wake up and pack my bag for Puerto Rico, because I'm going to Puerto Rico for 5 days. It's much needed. Look at this mark on my nose from my N95. Like, that better go away by the time I get to Puerto Rico. Look at me. Look at what I do to save lives and to help people. Like, you know, I just do what I can, you know? All right, friends, it is about 7:15 in the morning. I am done for the night and day. I am done with this shift, and I am done with emergency medicine for at least the next week as I go on vacation. You know, I only have one more shift left, and it's next week. It's next weekend. It's a night shift, and it's in the peds ED, which I love. But I'm so excited to be done, you guys, because I told you I was just looking forward to this rotation to get my fill, and I've gotten my fill. So I'm done, you know, I'm checked out. Today was enough for me, between the code, between the other patients that I was seeing that were just very kind of like over the top and needy and just a lot, you know, and it was just overall a long night. I'm exhausted, so I'm checked out. I'm done. So I'm very excited to go home, shower, get some rest, and then go to Puerto Rico. So I'm gonna relax and rejuvenate and then get it going. So I will see you guys next week for my final EM shift, and we will finish out this rotation strong, you guys, for my last Rotate With Me medical school vlog. So yeah. All right, friends, so I thought I was gonna have one more emergency medicine shift to bring you guys along with me for, but unfortunately or fortunately for you and I, the snowstorm happened and my shift was canceled and I was excused, meaning that I don't have to make it up. So legit, I didn't have a final shift. So yeah, I'm sorry I didn't get to bring you guys along for more, but I hope that you got to see a lot in this video. I hope that not only I did a great job of showing and introducing you guys to the field of emergency medicine, but hopefully you learned something through the clinical cases that we went through in this vlog and that you enjoyed it. Please give me feedback and comments and let me know if that's something that you liked and that you would like to see in the future, especially as I move on to residency, you guys, and as I learn more beyond the level of a medical student, that might be something that I incorporate here on our channel to keep the medicine going and to keep the vlog and the teaching going, and basically showing you guys not only what I'm doing, but breaking it down at a level that you can understand. So give me your feedback, let me know. But I hope you guys enjoyed this emergency medicine Rotate With Me vlog. It was a really good rotation, you guys. Although I personally am not going into the field of emergency medicine, I do have new insight and perspective and appreciation for the staff and the nurses and the doctors and what they do in the emergency room on the back end to bring the patients, you know, up to speed and diagnose and treat them and get them to where they need to go, to someone like me who's going to be up on the floors in internal medicine, seeing patients that are coming from that workup in the emergency room. So it definitely allows me a new perspective to see, you know, where my patients are going to be coming from and the work that has been done before I even get to see them, right? So I hope you guys enjoyed this vlog. If you did, please give it a thumbs up. Make sure you're subscribed and tune in to all the latest content. I hope to bring you guys more content, medical content on this channel as I transition to residency and kind of just figure out where this is all gonna go and you know, this newfound future and career path that I'm on. So wish me luck, you guys. And if you didn't, make sure you catch my videos about match week and match day, which is essentially the Super Bowl for medical students, and when I find out not only if I have a job, but where I am going for the next 3 years for my residency training in internal medicine. So as always, family, I love you guys. Stay safe, stay well, and I will see you next time.